seterusnya yang akan disampaikan sekali lagi oleh Profesor Madia Dr. Subapriya Suppiah. Apa membuat masa majlis mempersilakan Profesor Madia Dr. Subapriya Suppiah untuk menyampaikan ceramah beliau yang bertajuk SPECT-CT and PET-CT Image Processing and Analysis. Majlis dengan segala hormatnya mempersilakan.
Terima kasih Tuan Pengerusi Majlis. Okey. So, kita teruskan dengan lecture kita yang ketujuh pagi ni. Okay. Memang panjang kan dari pagi sampai sekarang kita banyak menimba ilmu. Dah tepu dah otak kot. So, I will make it like quite light this lecture so that you can just understand yang kita dah cerita dari pagi tentang MRI, PET scan, okay. Ada nuclear medicine imaging. Jadi kita nak fahamkan lagi, okay. Banyak kita dah cerita pasal functional MRI. So sebenarnya yang nuclear medicine imaging ni PET-CT mungkin ada yang tak begitu familiar. So this lecture is going to talk more about nuclear medicine imaging, the basics, okay. So but it will be like santai sikit, okay. No need to be so deep. So let's have a short intro about the hospital. Okay, we are now in Hospital Sultan Abdul Aziz Shah, UPM. Previously was known as Hospital Pengajar UPM. And we are 400 hospital-bedded hospital. There are many disciplines, including we have radiology and nuclear imaging unit. So this seminar is organized by the Unit Pengimajan Nuklear, Shah, with the collaboration of NeuroCoB Malaysia Society. And these are our staff. And we are, although a small unit, we receive referrals from all over Malaysia for nuclear medicine imaging. And growing busy by every day, every month. And this is our nuclear imaging center. It's a research-based center in the Faculty of Medicine, just next door. In the Faculty of Medicine and Health Sciences, we have a separate imaging building. There's a PET-CT scanner and MRI and ultrasound there. So in this PET-CT scanner center, we can do whole body imaging, which can look at glucose metabolism in the body. So knowing about different nuclear medicine modalities, we can delve deeper and know what is PET-CT, what is gamma camera, what is SPECT-CT, and using these different machine imaging, what can we do? We can compare the SPECT and PET. What is the benefit? If I do SPECT, what is the meaning? What if I do PET, what is the meaning? What are the type of radiopharmaceutical? That means something radioactive, we tag it with the drug, the pharmacy part. The pharmaceutical part tagged with the radiopharmaceutical, what can we do with it? And what is the atomic level interaction that gives us an image, how we acquire the image and how we can apply it clinically. Okay, so for the PET-CT imaging, it is a quite common looking scan which like has a donut, you know, the patient goes into the donut and then a scan occurs. What is different from CT scan? CT scan is the donut itself release the X-ray. So there is tubes. The CT scan tube release the X-ray to the patient and then you get the image at the detector. The difference for the PET scan is the machine itself is not radioactive. You inject into the vein a radioactive material and it distributes in the patient's body and that radioactive is detected by the scanner. So the patient's body contains radioactivity. Okay, so that's the difference between CT scan, X-ray, and nuclear medicine imaging. Nuclear medicine uses radiopharmaceutical injected or drink, ingested by the patient. For PET scan, most common radiopharmaceutical is 18F-FDG, fluorodeoxyglucose. So it's a glucose type of analog which is injected, and because it's radioactive, it will release some energy. So here some positron energy is released by the 18F-FDG molecule and it will have interaction with our cells. Our cells contain electrons, so when they langgar each other, they bombard each other, they will annihilate and release positron, and this in the form of photons, we call gamma rays or photons, which are very high in energy, 511 kilo electron volt in energy. They disperse in all directions, but the main direction that is linear to 180 degrees from each other, this is called line of the reaction. So this line will be detected by two opposite detectors and form an image. That's how we know the exact coordinate in the body, because only those in the 180 degrees from each other will be detected as a true incident. The others are all scattered and will be omitted by the software. So we know the exact coordinates. PET functioning, like I mentioned, we can image many body parts. We can do whole body scan by doing part by part. Even now, there's a new scanner that has multi-detector, can image the whole body in 8 minutes. Okay, I know United Imaging might be talking about later. Okay, so there is many advances in technology. Before, you can take like 20 minutes to perform one PET scan, but nowadays with advanced imaging technology, you can do faster scan. So that's the advantage from doing just a brain to doing full body. But today we are focusing on neuroimaging. So 18F-FDG, actually, you know, right, our brain uses a lot of glucose. So if the glucose analog you're going to inject, obviously everything's going to light up. So when do I know this is pathology or not pathology, right? So it's very hard. Okay, even Dr. Kamalia showed you a few FDG PETs. So you must be wondering how doctor can differentiate this area problem or this area hyperactive or this area hypoactive. Okay, so basically every area is lighting up, but there are softwares that can actually do thresholding. So dia akan tengok dari atlas, okay, a population of these many people, how is their brain glucose pattern. So if these people yang kita nak test, right, the one we're going to test, if dia punya range fall 2 standard deviation below or above the normal range, then you will say either hypo or hypermetabolism. So the brain maps are then developed to tell you, to light up, oh, this area, it kind of makes you see not all the activity, but it just highlight where is it above the normal population or below the normal population. So you can see regions that are more focused. So you can be easier to interpret more like semi-quantitative method. You don't just eyeballing because it can be wrong. It can be normal. Some people memang lah not homogeneous, right? The whole brain using the same amount of glucose. So you want to know, is it physiological or is it pathological? So this kind of thresholding helps. Many softwares are available depending on the machine you're using. So, you know, maybe a Siemens machine will have their own software, GE will have, you know, Cortex ID, and then we have Neurostat with this vendor independent. So there are many different software. So let's talk a bit more about other radiopharmaceutical. Yang paling common is glucose analog, FDG. But there are other types yang available overseas. Hopefully one day it'll be available in Malaysia. So we can use various. Yang paling common 18F ialah bahan radioaktif. But there are many others like carbon 11, nitrogen 13, oxygen 50. Semua ni bahan radioaktif. Some mostly produced by cyclotron. Kat Malaysia ada 3 cyclotron. So kita kena beli dari mana yang jual 18F ni. Bukan semua tempat ada. So kena beli siapa yang boleh produce and 18F paling mudah untuk transport kerana dia punya half life, jangka masa untuk aktiviti dia tahan separuh dari aktiviti dia 2 jam, lebih kurang 2 jam. So yang lain-lain berapa minit saja dan dia tak ada aktiviti yang cukup untuk imaging. Jadi hanya research center yang ada cyclotron boleh guna the others. Tapi F18 ni sesuai lah untuk transport. Boleh hantar melalui flight, boleh sampai Penang, you know. Boleh hantar flight sampai ke Johor walaupun dibuat di area KL atau Selangor. So F18 ni yang paling commonly digunakan. F18 pula boleh tag dengan glucose yang paling common, tapi boleh also can tag with FET, fluoroethyltyrosine, boleh tag with FLT, fluoroethylthymidine. Semua ni boleh berikan different gambaran otak because dia tidak purely glucose. So these are more protein or amino acid. You can get more focal uptake yang better. It gives you better lesion to background. Okay. So you nampaklah lebih jelas that tumor ke area yang affected. Okay, now we go to different machine pula. Gamma camera and SPECT-CT. What is different about a gamma camera and SPECT-CT machine? Okay, beza dia dengan PET ialah, okay, yang dulu-dulu yang paling ringkas, okay, atas tu. Okay, this one. Okay, this one is gamma camera yang paling basic, di mana dia ada kamera yang detect radiasi yang keluar dari patient. Kita detector ni tak boleh detect yang terlalu tinggi punya energy lah, macam yang 511 keV from positron emission tu dia tak dapat lah, dia tembus terus tak boleh get a good, so this one for lower energy, collimator dia boleh contohnya dalam 300 and below keV. Okay, so contohnya technetium. Technetium 99M is the radioactive material yang paling common guna untuk gamma camera imaging. Then can tag it with various pharmaceuticals for different body parts. Okay, so that is the most basic. And then later on, with the development of technology, we get hybrid scanners that don't only have the gamma camera, but also have a CT scan component. So when the image is acquired, and you can do rotational to get a SPECT image, you can actually fuse it, gabung dengan anatomy pula. So machine yang sama boleh buat imaging nuklear dengan anatomy, CT scan. So kamu boleh dapat satu gambar fusion, tahu fungsi dan tahu juga anatomical localization. Okay, that is SPECT-CT. And then banyak nuclear data ni boleh diguna kebanyakannya untuk cancer detection, but also for neurodegenerative, epilepsy, brain tumors, stroke, semua boleh digunakan bergantung pada what is the radiopharmaceutical. Okay, so this one menunjukkan all the different body parts, organ system, and then kita boleh lihat dari organ system ni ada yang boleh image brain. Contohnya technetium 99M HM-PAU. Okay, that is one type of radiopharmaceutical. It can be EDT, it can be so many different. For thyroid, you can use technetium pertechnetate. Okay, you can use NIBI even. For lungs, you can do the VQ scan. So there's very different radiopharmaceutical for different body parts. For the bone, you can use MDP, methyl diphosphonate. So phosphonate ni pergi bone seeking, so they tag to the bone. Kidney, DTPA, MAC3, those are examples. Okay, the MSA. So these are various radiopharmaceuticals. So when we inject this, okay, vial kat bawah ni, this is the bottle of technetium. We combine it with the cold kit specific to the different type of body part that we want to image. We inject it into the patient intravenous, and then we can perform the scan after the uptake time has taken place. And then we can acquire the image of specific organs, the function. Okay. So these radiopharmaceuticals have different compound, different function. If you use technetium, the half-life is berapa lama? 6 jam ya. Kalau kita guna iodine, 8 hari. So different radioactive tu ada different half-life. Macam F18 tadi berapa lama? 2 jam. Okay. So different radioactive material have different half-life. Okay. Regional cerebral blood flow can be assessed with HMPAO, for example. So we need to know how to do patient preparation, how to do the scanning using the correct equipment. Okay, so this is how they take out the technetium from the technetium generator. So technetium you can buy the generator, it will be delivered to you. Okay, so this one you can use it for maybe 1 to 2 weeks depending on how much of volume of your patient. So dia tahan. Dia ni macam satu peti sejuk yang ada storage. Okay, kamu boleh tarik je berapa banyak kamu nak untuk digunakan untuk patient setiap hari. So dia tahan selama 1 atau 2 minggu. Lainlah macam F18 kena beli setiap hari. Sebab lepas 2 jam dia dah hilang dah dia punya energy tu. Okay, so this one dapat dihantar ke many centers. That's why the nuclear medicine yang ni, kita panggil general nuclear medicine, lebih banyak center yang boleh mampu sebab dia boleh tahan lama. Whereas F18 ni mahal sikit untuk buat PET scan. Okay, so maybe limited centers or banyak yang private center dekat Malaysia banding government or public centers. Alright, so as I said earlier, for brain perfusion imaging, there can be several radiopharmaceuticals, HM-PAU for example, or ECD. So there are pros and cons of using both. We won't go too deep into that, but just to know there are various radiopharmaceuticals, and we can use it for human studies, animal studies, to learn about disease pathology, and also cellular level to learn the physiology, to learn pathophysiology, to maybe create new medications, learn at the cellular level. So there are many from bench to bedside kind of imaging that can be done. Okay, so bandingkan SPECT-CT now with PET-CT. Okay, dua jenis modality yang berbeza, kita bandingkan sekali lagi. Macam jenama X dengan jenama Y. Okay, alright. So we're looking at two different modalities. The SPECT that is using a gamma camera as the basic unit, and the PET imaging. So the detection is single detection that's going one way, you know. So if you're detecting from here, you're detecting anterior view. If you're detecting behind, it's the posterior view. But it can also do rotational, but it's only detecting one directional rays coming out of the patient. Whereas PET scan, you know, is scattered all over, at least bi-directional you're going to detect. The other coincidence, all you will be considered as scatter, right? Then the radionuclides are different. Shorter in half-life usually for the SPECT, like technetium 99M, whereas for PET is more commonly F13. And then the energy levels also higher in the PET, lower in the SPECT. Spatial resolution of course is much better in PET. Okay, jadi lesion, contohnya lung tumor yang kecil, about dalam 0.8 cm pun boleh detect clearly on the PET scan, but SPECT may be a bit blurry. Okay, so the image resolution, the sharpness of getting the spatial resolution is good on PET. And then we can do attenuation correction better on PET. But nowadays with SPECT, you know, using a CT scan component, you can improve that as well. Okay, so sekarang dengan teknologi hybrid yang ada dua teknologi dalam satu mesin, can have improved attenuation correction. Dulu kadang-kadang kalau kita nak image heart, bawah ada bowel dekat, so kita susah nak tahu ni dari heart ke dari bowel. Tapi dengan sistem CT yang boleh improve the attenuation correction, a lot of technical advances di mana kita lebih accurate lah dalam diagnosis. So now tadi kita dah bandingkan jenama X dengan jenama Y, kita pergi more detail on PET. Okay, we will just talking about PET now. Okay, so for PET, we've mentioned it's very useful for neurodegenerative disorders. Walaupun FDG ni like all over the brain, you can see, but it has its role because it's more commonly available. And more commonly, the low areas are the problematic areas lah for the neurodegeneration. Sebab area yang kurang glucose, maksudnya mungkin sel dia dah rosak. The cellular function is impaired. That's why you have low glucose perfusing there and therefore leading to the cognitive deficit in that region. So the brain imaging for the neurodegenerative more to detecting hypometabolism. But the color coding you have to be, tengoklah dia punya sidebar tu. Sometimes warna merah tu mengatakan hypo. Walaupun kita rasa merah tu hyper kan sekarang kan. But it depends. Kita tengok color coding tu kat bar tu untuk tahu ada detecting like higher standard deviation from the low part or the higher part. Then you will know, oh, I'm detecting hypometabolism actually. Okay, so you look at the color coding in the bar. And then we go to amyloid scans. Okay, Dr. Kamalia mentioned is more specific. It's looking at amyloid deposition in the brain. So that can be more specific to Alzheimer's, depending on the clinical findings and also which areas it is distributed. Okay, because there are some other dementias that can also have amyloid angiopathy. That means ada juga pathology amyloid. Tapi tak seketara Alzheimer's. Alzheimer's memang very high in the beta amyloid deposition. Okay, then we go to brain tumor. Okay, brain tumor ni kerana dia agresif, dia akan guna glukos dengan banyak. So kalau kita buat FDG scan, dia akan lebih hypermetabolism, lebih tinggi penggunaan glukos. Tapi susah juga kita nak tahu berapa besar tumor ni sebenarnya. Banyak besar area yang menggunakan glukos, betul ke tumor tu that big. So that's why sometimes we do multiple radiopharmaceutical to know more accurately. So there are various other better tumor to background ratio, like using carbon-11 methionine to look for hypoxia. Sebab kan brain tumor dia boleh ada necrosis, dia boleh ada cell death sebab dia terlalu pesat membesar. Ada area yang akan kurang salur darah ke situ. Dia akan ada hypoxia dan necrosis. So those areas boleh light up more at the periphery because they are very hypoxic areas. Belum die, you know, almost want to die. So they are hypoxia and they will tend to take up the methionine. And then got FET, FLT also to give you more idea of how proliferative is the tumor. So this helps the surgeon, especially also to, because surgeon nak memastikan tumor tu boleh dikeluarkan ataupun bagi radioterapi yang lebih tepat. Tapi pada masa yang sama tak nak efek other parts of the brain, nanti dia boleh lumpuh kalau kita terlalu besar area yang kita nak keluarkan atau irradiate. So dia is very accurate treatment planning. Kita perlu banyak modality untuk lebih jelas. Sometimes tengok struktur je tak nampak how much the tumor has spread in the cellular level. Okay, so that is so useful for that. And the quantification, as I done with one of my previous master student, currently PhD student, we do the SUV measurement to know how accurate we can quantify the amount of glucose taken up by certain body area. Okay. And like I said, ada software kan yang boleh kata adakah dia hyper or hypo. Kita tak payah nak tengok je dan tentukan. Software ni dapat bagi the map. Jadi dia akan bagi values. Okay, jadi kita boleh fokus. Oh, area ni yang bermasalah. Okay, so this is macam Dr. Kamala tunjuk tadi. Dia dah proses. Dia tunjuk je area yang low in metabolism. So dia highlight tempat tu. So contohnya NeuroSpect software. Dia highlight untuk Alzheimer, precuneus, posterior cingulate. These areas are more hypometabolism because it's shown in the software. So we can be more certain. The other parts that are in normal anatomical distribution of glucose is removed from this. It's a process image. We call it the 3D SSP image. So it is highlighting the surface cortical glucose utility and giving you the ones that are beyond the 2 standard deviation from normal population. So it gives you a better semi-quantitative way to look at it. Rather than you deciding really, is it low or is it high? Okay, so there are softwares to help. And last but not least, this is to share with you that we're not just doing imaging in nuclear medicine. We can actually give therapy using this radiopharmaceutical. This radiopharmaceutical, if you tag with higher energy type of radioactive materials such as lutetium or yttrium, they are higher in energy. They release beta radiation, not gamma only. So they release this beta radiation that are higher in energy, can kill cells at a shorter range. So they can target to certain lesions and cause cell death and can be a targeted therapy. Okay, so these are advances in nuclear medicine. Dia bukan saja untuk pengimajan, not just for imaging, can be also for therapy. For example, patient with prostate cancer, tagging with lutetium PSMA, dari banyak metastasis satu badan dah kurang after 2 cycle of treatment dengan gunakan nuclear medicine therapy. So there can be advances maybe in the future for brain type of tumors. You know, you don't need to go and operate. Maybe there can be tagging with certain radiopharmaceuticals that can target. You know, there have been actually. There's a doctor in India shared with me the story. He had a patient with glioblastoma. The surgeon said, I cannot operate. I think 50-50 better the patient don't do it. Very risky. Then they just tried with a radiopharmaceutical and it worked. Lutetium PSMA. Walaupun PSMA is more for prostate, somehow they had some cellular receptors that in the imaging said, okay, there's some receptors, it's picking up. Why not give a try for lutetium? And they tried and it actually shrunk the tumor. So, you know, there can be some improvement in brain tumor as well. So finally, to summarize, the importance of nuclear imaging and theranostic, therapy plus diagnostic, is that we can do early diagnosis, we can characterize the disorder, and we can do surgical treatment planning as well as therapy. We'd like to just share with you some images of our hospital, our research center where we do the PET scan. And we have various collaborations. I would like to appreciate, you know, our sponsors, United Imaging Healthcare, who are our platinum sponsor, and Synthetic MR, our gold sponsor for today's event, and our collaborators from international who have joined us on Zoom. For example, Dr. Professor Kenji Hirata from Hokkaido University, Japan, and his team. We got to know him during our visit. My PhD student, Anusha Hidato Nabila, also went with me to Kyoto, Japan during a nuclear medicine conference last year, and we have a lot of collaboration now with the counterparts there. So thank you for supporting our program. And also from Universitas 11 Maret, Indonesia, headed by Dr. Rashmi Fauzia. She's the radiologist in the university there. So they also support us by joining us via Zoom today. So really appreciate all our collaborators. And with that, I thank you.